Hello, I'm Kiana Wagler, and this is my presentation from Diversity in Healthcare about what I learned this semester. So, a little brief overview of what I'm going to be talking about. There's 5 main points. The first one is communication, second is pain, third is religion and spirituality, fourth is family, and 5 is end of life. So, the first one I'm going to be talking about is communication. Locally, these are some of the things that happen. Cultural competence develops through daily interactions. Language barriers are addressed, and health education programs promote important topics. So, communication, you have to learn everyone's language needs and their health practices by communicating with them directly, and this builds a lot of trust. It also can really bring out some of the inequities that are associated with it. If you're not careful, you can run into these problems. So nationally, training standards and guidelines display cultural humility, media networks report on disparities, public health campaigns normalize diversity, and policy communication signals what a nation values. So some of these organizations like the CDC, NIH, AMA, and ANA communicate expectations around like equity, bias reduction, and inclusive care. The news media also really contributes to this, so they report on things that may need to be changed. Globally, so global health organizations share equity guidelines. Research communication exposes global disparities. Cross-cultural communication builds global confidence, and migration patterns spread diverse health beliefs across borders. So, again, with a lot of organizations, they communicate universal principles about human rights, cultural respect, and access to care. And this really helps with the many immigrants that live in our country. It allows them to communicate with their healthcare providers greatly so that they are given the best possible care that they can get. So the impact that this has on us as a whole, it affects the quality of care, shapes trust, reveals and reduces bias, supports cultural competence, and ensures access to resources. The second thing I'm going to be talking about is pain. So locally, different cultures express pain differently. Providers may interpret pain through their own cultural lens. Biases appear often, and language barriers affect pain reporting. So a lot of different cultures in your local area, they express pain differently. I know I did a research project. I wrote a paper on the Amish, and I asked them a few questions about how they deal with pain, and a lot of times they don't express it, or they don't show how severe it is because they don't want to appear weak. Nationally, national data on pain disparities reveal racism and inequity. Public health agencies highlight inequities in chronic pain. National opioid crisis changes unequal treatment. Professional guidelines emphasize equitable pain management. So a lot of this national data on pain, it can reveal, like I said, a lot of the racism and biases that unfortunately providers have against their patients. I think that in order to treat everyone's pain equally, they need to understand the culture that they come from and really emphasize that they are allowed to feel pain and it's not an issue. And globally, unequal global access to pain relief, different culture beliefs about pain, and global organizations highlight pain as a human rights issue. So a lot of times, different places around the world don't have access to all of those nice pain meds that we have here in the U.S., and it can really contribute to a decline. It's really sad because people can ultimately be suffering, and there's just no way to relieve any of that pain. The impact that this has is pain expression varies by culture. Cultural beliefs influence how pain is understood. Communication barriers, bias and stereotyping, and pain reveals systematic inequities. So the third thing I'm going to talk about is religion and spirituality. Locally, religious beliefs guide decisions, providers must navigate diverse spiritual needs. Local hospitals adapt practices, and misunderstanding religious values may cause conflict. So, a lot of times, locally, most of the people in my community are Christian, but every once in a while you can run into Jewish, Hindu, all different religions and spiritual needs, which can require different things, like simple things such as even just their eating. They might require a special diet, like Orthodox Jews only eat kosher foods. Some people may fast. There's definitely a lot of different local things that need to be addressed as far as religion and spirituality. Nationally, national debates on healthcare issues, national health guidelines emphasize spiritual assessment, faith-based health organizations influence healthcare delivery, and public health campaigns must consider religious practices. So, a lot of national health guidelines really have been pointing towards spiritual assessment as to where the patient is at spiritually or what they believe and how these beliefs may contribute to their overall health care. Globally, global health systems interact with wide religious variation. International health organizations emphasize respect. Global health crises require culturally informed responses. Refugee and immigration movements spread religious diversity and traditional and indigenous healing systems. So, the global impact with wide religious variation, there are so many different religions around the world, and depending on where you're at in the world and where you're treating people, this can really lead to some big differences. It seems like most providers tend to practice the religion that is associated with their area. So like I said before, most people in our area are Christian. Some may be Catholic, but that kind of goes hand in hand. It's along the same thing. And when you get someone that's from a different religion, it can also be very difficult to understand why they do the things that they do. And this around the world can lead to crazy disruption in the healthcare system. And this it shapes patients' health beliefs and decisions, influences communication and trust. Diverse spiritual needs require inclusive healthcare practices, and it reveals provider biases and ethical challenges. The fourth thing I'm going to talk about is family. So locally, different cultures define family differently. Family roles vary across cultures. Families influence communication and trust, and family support affects treatment and outcomes. So a lot of different cultures, depending on where they're from, they can involve family differently. Some people value autonomy, like in the U.S., that's mainly how we are. But in other cultures, they might want their family members to make all the decisions for them, and it's important to know this before you decide to treat the patient. Nationally, national health policies consider diverse family structures. Healthcare services may accommodate cultural variations in caregiving. Insurance and healthcare laws reflect evolving definitions of family, and national health campaigns target families differently. So, I really noticed the insurance part of this. Depending on how your family is, I don't know, there's a lot of different ways to classify family. But insurance can really be a big thing because if you're not covered or your family's not covered, this can really cause a lot of disparity. And globally, cultures vary widely in family-centered versus individual-centered healthcare. Global health organizations must consider family norms. Migration spreads diverse family norms, and family involvement in birth, death, illness, and caregiving varies. So, some families come in and they expect you to take care of the patient. They're just there for emotional support. While in other cases, some families might come in and take care of the patient completely. You're just there to kind of monitor them and make sure that they don't take a turn for the worst. And this can be really confusing to some people in certain hospitals. And the impact this has is it shapes health beliefs and decision making, influences communication patterns, roles affect caregiving expectations, shapes emotional support and health behaviors. Diversity highlights equity and access issues and encourages culturally competent care. And the last thing that I'm going to be talking about is end of life. So locally, different cultures define a good death differently. Cultural beliefs influence decisions about life support, code status, and comfort care. Family involvement varies, and local providers must understand diverse spiritual and cultural practices. This kind of goes hand in hand with the religion aspect of it. A lot of different cultures like to perform different rituals at end of life. They have certain preferences on what to do with the body and how to take care of it, and you just need to be very upfront with these patients and figure out what their preferences are. Nationally, national debates about hospice, palliative care, and medical aid in dying, end-of-life disparities show systematic inequities. National guidelines emphasize culturally competent end-of-life care and public health campaigns around advanced care planning. So, there's a lot of different debates about hospice, palliative care, medical aid. I know that it can be a real issue across the world. Sometimes people aren't getting the care that they need simply because they don't have that much money, or they come from a low-income household and can't afford it. I think this has really become a national crisis because we would love to see all of our citizens treated with the care that they deserve. And globally, beliefs about death vary dramatically across cultures. Access to pain relief and hospice care is globally unequal. Religious traditions shape global end-of-life practices, and global migration increases cultural diversity in hospitals worldwide. So, again, with the migration, people around the world view death differently than what we do here in the U.S. It's just part of diversity in general. So, if you're traveling somewhere else to take care of people, or if you get like a different cultured person as your patient, you really need to consider these things during end of life because they can react differently. And then the impact is differences in beliefs about health and dying, treatment preferences and use of life-sustaining interventions, family roles and decision-making, spiritual and religious practices at end of life, pain management beliefs, communication styles at end of life, and views of hospice and palliative care. So my role in making a positive impact, just in general, I have these 3 statements. I feel that I have a duty to treat everyone with kindness and respect, a duty to accommodate specific needs involving language barriers. I have a duty to ask patients about their cultural considerations before treating them. I think if I can continue to do these 3 things, every patient that I come in contact with will have a good experience. And then steps to advocate for the Amish. So I chose the Amish because, like I said earlier, I did a paper on them earlier in the semester, and I think I could ask them about their preference regarding the opposite gender provider and physical exams, ask who is the decision maker in the situation, ask if they have been using any alternative medicine or home remedies, and frequently ask about pain. And then these are my references. Thank you for watching, and I hope that you learned just as much as I did in the semester.